I am Dr. Joshua Royce. I'm a thoracic medical oncologist, and I specialize in the care of patients with thoracic malignancies, including lung cancer, mesothelioma, and thymoma. So the patients I see in my practice are patients that have a diagnosis of a cancer in the chest. Typically that is lung cancer, although there are other malignancies we treat as well, including thymoma, which is another cancer that originates in the top part of the chest, as well as mesothelioma, which is a cancer of the lining of the lungs. We see patients that are referred to us from other providers in the area, as well as patients that are diagnosed in our hospital or who come through our multidisciplinary clinic, where I see patients together with other specialists, including pulmonologists, radiation oncologists, and surgeons, so we could tailor our care to the patient specifically. So my philosophy with my patients, I strive to treat the whole person and not the patient. I like to tell my patients, I want to treat you as, you're more than a patient, you're more than your symptoms, you're a person, you have your unique lifestyle, your unique beliefs. So I want to really get to know my patients and the people that they are. And I think by understanding them better, we can develop a closer connection, so that's really something I strive for. Well, the future of oncology and thoracic oncology in particular, I think is very exciting. We now genetically profile all of our patients so that we can get a molecular and a genetic readout of their cancer that allows us to tailor our treatments for our patients. And so I like to say, we're not looking for the fastest therapy, we're looking for the right therapy, for a therapy that's tailored specifically to you. And that's something that's only going to improve. We're identifying new and new alterations, new and new pathways that we can target so that we can really aim to shrink cancer, to keep cancer away for as long as we can in every patient that we see. So what I really love about my job, it's things that got me interested in the field to begin with. It's the science, the scientific advancement, the ways that we're really pushing the boundaries of our therapies, the ways that we can design trials, that we can really bring new treatments, work with foundations, work with other collaborative groups to tailor and design studies for our unique patient population. So that's one thing. I think really the thing though that I derive the most meaning from are my interactions with patients themselves. It's those memories of an encounter with a patient, a conversation, something that it really sticks with you. It sticks with me. And so it's the things that really make me smile at the end of the day are the days when I'm seeing patients and the days that I'm able to really just get to know my patients, to really have good, meaningful conversations. We take a multidisciplinary approach to the care of our patients. So we have a multidisciplinary clinic where I, as a medical oncologist, am seeing patients together with my pulmonology colleagues, my radiation oncologists, my surgical colleagues. And this is great because we're able to tailor our treatment right there and then for our patients. They're able to ask questions to all of us, and we're able to really come together to say, this is the treatment that we recommend to you. And I think beyond that, we really strive to care for the person, not the patient. Again, it's not just your symptoms, it's not your cancer that we're treating you. We really need to tailor our treatments and our strategies to the person, not the cancer, and that's something that I strive to do every day. So lung cancer is a cancer that originates in the lung tissue. And so for some patients, for still a lot of patients, there is a risk factor for this, which is smoking. And but that's not the case with everybody. We are seeing a growing proportion of patients who develop lung cancer who don't have a history of smoking. And these are in particular the patients where we see mutations in the cancer themselves that is causing the cancer to grow. So I'll tell patients this is not a mutation in general that you can pass to your family, to your children, but it's something that's causing the cancer to grow and that we hopefully can target with pill therapies, the list of which continues to expand. There are several types of lung cancer. Our broadest breakdown tends to be between what we call non-small cell lung cancer and small cell lung cancer. Small cell lung cancer is almost exclusively associated with smoking and is the most aggressive type of lung cancer. Non-small cell lung cancer, also commonly associated with smoking, is less aggressive than small cell, and this is the cancer type where we've seen the most innovation in terms of immunotherapy and targeted therapies, where we can really personalize our treatments for our patients. So there are several things that we know of that cause lung cancer, the most common which being cigarette smoking, but exposure to other toxic chemicals. For mesothelioma, which again is a cancer of the lining of the lungs, the common exposure is asbestos, which can be anywhere from contract construction workers working in old buildings to ship makers. So these are some of the exposures that we think about, but there are patients that develop lung cancer that don't have any known exposures, and these are the patients that tend to have mutations in their cancer that causes it to grow. And these patients in particular are ones that we do genomic testing on both their tumor tissue and their blood to look for mutations that are driving this cancer to grow, that we can target with pills that really have revolutionized the treatment and the care of these patients. So warning signs for lung cancer, in its earliest stage, there are very few signs for cancer, and that's why we have expanded screening for patients with lung cancer with low-dose CT scans. Once the cancer is spread, oftentimes we'll see symptoms like shortness of breath, cough with blood, but even things that are a little more insidious like more increasing fatigue, weight loss, energy loss. And then depending on where the cancer is spread, you can see pain in these areas, whether that's pain in your chest, pain in your bones, and rarely headaches and nausea and vomiting if the cancer has unfortunately spread to the brain. So when I see a patient in my clinic, one of the most important things that I need to do is determine the best treatment approach for my patient, something that's unique to them, that's tailored to them. It's not about the fastest therapy, it's about finding the right therapy. And to do that, I need to do additional testing, additional molecular and genomic testing on the cancer tissue and on patients' blood so that we can find the right treatment for patients. This is something that is exquisitely important, and I think it can be a source of anxiety for patients because you're diagnosed with cancer. You want to start treatment as quickly as possible, but it's really not about finding the fastest treatment. It's about finding the right treatment. And so that is really one of the advantages to coming to a place like MedStar Georgetown, where we can offer these testing as quickly as possible so that we can get that answer and then tailor the right treatment to you. I think one of the biggest things on patients' minds once they've been diagnosed with cancer, with lung cancer, any cancer really, is, well, when can I start treatment? I think oftentimes the unknown is one of the most stressful things. And so when I'm discussing this with my patients, I talk to them about what information we need. Sometimes this might require more imaging. For example, if patients have a new diagnosis of a lung cancer, we need to scan the brain to make sure there's no cancer hiding in the brain. It's very important. Of equal, if not more importance, is that we're doing additional testing on the cancer by testing the tumor tissue in the blood to see if there are any unique mutations in the cancer for which we could really hone in and target our treatments in a precision oncology method for our patients. This takes time. This takes several weeks usually. This is what I tell my patients, that this process can take several weeks. Now, we do have treatments that we can offer right away for patients that have symptoms that we think can be imminently life-threatening. But again, we're looking for the right therapy, not the fastest therapy. And this is what I tell my patients and tell them to expect while we're waiting for our answers. And that's why it takes several weeks oftentimes before we start therapy for patients with a new diagnosis of advanced lung cancer. So lung cancer treatment involves several different approaches, several different strategies depending on the stage of the cancer. When cancer is metastatic or spread beyond the confines of the chest, medical oncologists such as myself probably take the leading role, where we give treatments such as chemotherapy, immunotherapy, and targeted therapies, systemic therapies that go throughout the whole body to treat and shrink the cancer. When the cancer is more localized, this is in particular where multidisciplinary care is very important because we see strategies that incorporate not only medical treatments but surgery and radiation to try to completely eradicate the cancer and cure patients of their cancer. So there are several side effects, and it depends on the type of therapy. So the side effects from surgery and radiation are are unique to the targeted aspects of those approaches, surgery being bleeding, pain, infection risk, radiation being side effects depending on where the radiation is targeted. For chemotherapy, immunotherapy, and targeted therapies, the side effects range significantly. So I think most patients really think of chemotherapy. They think of chemotherapy side effects. They think of significant vomiting, that they're really going to be completely disabled by their treatments. That's really not the case anymore. We have medicines that we give in the IV, pill therapies that we give to really help control these symptoms. And with our newer treatments, immunotherapy and targeted therapies, the side effects are really less pronounced overall. Immunotherapy, the most common side effects we see are maybe some mild fatigue, but most patients do very well. That said, there is a unique class of side effects associated with immunotherapy called immunotherapy-related toxicities. And what I describe to my patients, these immunotherapies rev up your immune system to fight the cancer, but sometimes the immune system can get revved up and go after normal areas in your body. So these, while many cases tend to be mild and can go away with stopping the medicine or with steroids, they can be severe, they can be significant, they can require hospitalization, they can have risk for death. And so we need to be closely monitoring patients for this unique form of adverse event that is very different than chemotherapy. So mesothelioma is a cancer of the lining of the lungs. So the lungs are kind of wrapped in almost like a clear cellophane lining called pleura. And when cancer develops in that, we call it mesothelioma. Mesothelioma is most common in patients that have exposure to asbestos. And in many cases, like with lung cancer, the symptoms that develop can be insidious at first and can be really slow onset. This is a very rare type of cancer, so it's very important that for people that get this diagnosis, they seek care at a multidisciplinary center with experts that have experience in treating this type of cancer, and that they seek out trials and unique treatment approaches for this type of cancer. So thymoma is a cancer of the thymus, which is an organ that is involved in immune cell development. It's most active when you're young, and as you age, it kind of becomes more of a fatty structure in the front part of your chest. But in very rare cases, this can become malignant and cause a cancer to develop. It's a very rare cancer, one subtype called thymic carcinoma. There are less than 100 or around 100 diagnoses per year in the United States. So like other rare cancers such as mesothelioma, it's very important that these patients seek expert care at comprehensive cancer centers such as MedStar Georgetown, where they can get unique expert opinions for the care of their cancer. So immunotherapy has really taken the cancer world by storm over the last decade, and it's really revolutionized the care of many cancers, including lung cancer. So when I talk to my patients, I explain immunotherapy works very different than our other treatments, such as chemotherapy, and it works by really activating one's own immune system to go after and target and attack the cancer, which is very different than chemotherapy. And so it's a novel treatment, and we're very excited about it because we see patients that can have very long-lasting responses where the immune system really has awoken and is able to control the cancer, not just for weeks, months. We're talking about years, and we're reaching a point where can we say that patients with advanced cancer are cured of their cancer? So we've learned much more about cancer in the last 10, 20 years, and that one of the hallmarks of how cancer can grow and spread is by hiding from the immune system. So immunotherapy really works by re-exposing the cancer and awakening one's immune system to the cancer to allow the immune system to recognize the cancer and attack it. And so immunotherapy really works by revving up the immune system, but sometimes that revving up of the immune system can cause the immune system to go after other normal areas in your body. And so when this happens, it causes inflammation in that area, or in doctor language, itis. So in your lungs, that's something called pneumonitis that can cause shortness of breath and cough. In your skin, that's something called dermatitis that can cause a rash. In your gut, it's something called colitis that can cause diarrhea. And so us as oncologists really have to be on the lookout for these side effects. And in many ways, cancer care has become even more multidisciplinary because of that, because we're oftentimes involving other specialists, pulmonologists, gastroenterologists, cardiologists, other specialists to really help us in giving the best care of managing patients who are on immunotherapy. So our goals in treating cancer are obviously to cure cancer. And once cancer is spread from the place that it originated, that's very hard and almost impossible. And so many cancers have screening to try to pick up the cancers sooner. And lung cancer is one of these cancers where we offer cancer screening to patients that have risk factors that we know about for the development of lung cancer. And so with the implementation of screening programs, which involve a CT scan of the chest, we are able to diagnose cancer sooner at a stage where it can hopefully be cured. And in those settings, we refer to the cancer as a localized or a locally advanced lung cancer. And treatment of these patients involves a multidisciplinary approach with surgeons, with radiation oncologists, and with medical oncologists such as myself, so we can optimize the care and really increase our chances of curing the cancer. While our goal with patients with localized or locally advanced lung cancer is cure, we are more often than not able to meet that expectation. Unfortunately, over half of patients who are diagnosed with a localized lung cancer experience recurrence of their cancer and will inevitably succumb to their cancer. So we really need to push, how can we improve this? How can we really meet this unmet need in our field? And so one of the ways is by moving some of the treatments that have really revolutionized the care of patients with advanced lung cancer and moving that into the realm of patients with localized lung cancer. And that includes therapies such as immunotherapy and targeted therapy. With immunotherapy, we know that patients who have a more localized lung cancer tend to have a more active immune system at that stage. So if we can rev up an already more highly tuned immune system, our hope is that we can really ensure the cure of patients with lung cancer and really improve the chances of meeting that goal of curing patients of their cancer. So in addition to immunotherapy, which we are now involving in clinical trials, and I anticipate will be approved very soon for the treatment of patients with localized lung cancer, we are also taking our targeted therapies that we have for patients with advanced lung cancer and moving that into this setting as well. Now, targeted therapies are treatments that actually target unique mutations in cancer. They only work for patients who have this mutation, and so that's why it's important that we screen all our patients, both their tumor tissue as well as their blood, for these mutations so that we can pick them up and identify them. It has become the frontline strategy for patients with advanced lung cancer, and for patients that have a mutation in the gene EGFR, we now have Tagrisso or osimertinib approved for patients who, with EGFR mutant lung cancer, who undergo surgery, can then get this targeted therapy. We know that that has improved the likelihood of this cancer not coming back. So at MedStar Georgetown, we have trials, clinical trials for patients of both immunotherapy and targeted therapy that can be given both before and after surgery, with the goals of really increasing the chances for long-term cure of their cancer. We have a multidisciplinary clinic that's composed of specialists, not just medical oncology, but radiation oncology, thoracic surgery, as well as pulmonology. This is very important for the care of our patients because multiple specialties are involved in treating our patients. And not just at diagnosis, but at times of disease progression, there are points where we need biopsies, there are points where we might need to do radiation, and we need to get these answers quickly. We need to get them comprehensively, with our whole team coming to a mutual decision on the care of our patients. So That is why it's very important that patients seek out multidisciplinary care at an institution such as MedStar Georgetown, where you can get unique subspecialty input concurrently at one unique time point in the care of patients. Multidisciplinary cancer care is very important for several reasons. So patients need to oftentimes get opinions from surgeons, medical oncologists, radiation oncologists, and if you have to make separate appointments, that can take time. That's time that you're not getting treated for your cancer. So by having a multidisciplinary clinic, you get those 3, 4, 5 opinions all at once. And not only are you getting those opinions, but you're able to ask questions of the providers for which those questions are most relevant. There are certain questions that are relevant to me as a medical oncologist that aren't relevant to a radiation oncologist or a thoracic surgeon. And so you're getting a multidisciplinary answer. You're able to really come up with a plan and address all questions that a patient has all at one appointment. One of the questions I'm frequently asked is, how can supplemental therapies be utilized to really maximize my ability to get through treatment, or what can I do to really increase my chances? And so that oftentimes will revolve around nutrition, and it will involve around any other supplemental or herbal therapies. And so at MedStar Georgetown, we have experienced pharmacists, nutritionists, people that can really be involved in the care and really help to maximize these things that I myself don't always have expertise in, because my approach really is that if it's not going to hurt you, I don't have a problem with it. So, and with nutrition in particular, I think a lot of patients are concerned, well, is too much sugar bad? Is too much protein bad? And, you know, what I tend to say is, look, you need to get nutrition into your body to be able to do your best with treatments. And so that involves a balanced diet like with anything else. There is really rarely a unique cocktail, a unique something that I recommend, as opposed to really just a balanced diet, which oftentimes needs to be supplemented with nutritional supplement things to really get packed calories into somebody so that they can really do their best with treatments. And that's oftentimes where our nutritionists and our pharmacists can be very helpful in helping to guide this. We have lots of trials available for our patients at MedStar Georgetown, and these are studies that range from investigation of drugs that are just coming up to drugs where we're really on the precipice of really changing the landscape of treatment of our patients. And so really our goal with every patient we see is to try to find a clinical trial that they can enroll on that really can try to maximize and improve their chances of long-term benefit with their cancer. I myself am involved in the development of several clinical trials at Georgetown that are looking at incorporating novel immunotherapies, novel targeted therapies that aren't yet approved for our patients, and bringing these to our patients to maximize their care. And beyond that, I'm working with scientists at our university to see how we can learn more about the cancer and how we can really uncover more information that will illuminate our best treatments. We strive to make available clinical trials to all of our patients. And so really it was the responsibility of the care team to identify whether a patient is eligible or not for a clinical trial. So if a patient has a question, their best thing to do is to call us, to really engage us, see us for an opinion, and where we can really profile them as a patient, look at their other medical conditions, look at unique aspects of their cancer that might make them a good candidate for a trial or not. So for patients who enroll in a clinical trial, I think one of the most important things to communicate that is the majority of your care really does not change. We are still doing imaging to make sure that your cancer is responding to treatment. We are still evaluating you regularly. We are still doing all the things that we would do even if you weren't on a clinical trial. But if anything, we are really paying even extra attention to side effects that you might develop. We might take a little bit more blood or utilize some of your cancer tissue to do extra tests on the cancer itself. but the majority of your care really does not change because we are still, at the end of the day, taking care of you as a person to treat your cancer. So the eligibility for a clinical trial really depends on each unique study and on the patient that we're seeing. So at the end of the day, it is the responsibility of the physician, such as myself and the research team, to determine eligibility for a clinical trial. That said, there are some common things that seem to permeate these trials. We want to see someone who is generally in relatively good shape, that has someone who has normal organ function and has perhaps few comorbid medical conditions. That said, there is no reason not to see us, to ask us, hey, is this a study that I can be a candidate for? Now, how can you find a clinical trial? Now, there's clinicaltrials.gov, which is a common site, but it can be very difficult to navigate. So, I definitely recommend patients talk to their physicians, whether that's a local oncologist or someone that I myself am seeing. I am constantly surveying the trial landscape, talking to my colleagues at other institutions to see, is there a trial that works for that particular patient, that particular person? Because again, at the end of the day, I'm looking to find the best treatment for the person who's sitting in front of me. So at MedStar Georgetown, we are an NCI-designated comprehensive cancer center, and I think there are several benefits that come with that. You are getting an experienced team, top to bottom, that has treated many patients with cancer, that have all trained at exquisite institutions, that have really a track record of success in treating patients, and that extends beyond medical oncology. That's radiation oncologists, that's pulmonologists, that's surgeons. When we all work together to find the best care for our patients, we oftentimes will also have a really large clinical trial portfolio, so your chances of finding a clinical trial that works for you are really quite high if you see someone at an NCI-designated comprehensive cancer center. And once you're plugged in, you're always plugged in. So let's say it works better for you to get care locally because you're driving 2 hours away, 3 hours away. Those things can be really big barriers, and I completely understand that. But I will always be plugged into the care of my patients who are getting treated by other physicians, working with them so that if their cancer progresses, if things get worse, I can then be involved to help coordinate and improve care, whether that's in a clinical trial, seeing us for another opinion, or contacting colleagues at other places across the country to see how we can maximize their benefits.